evening, everyone. Thank you so much for taking time out of your Friday evening to join us in our last webinar of the week of Bone Cancer Awareness Week. So I'm just going to share my screen with you. So just let me know when you can all see that. Good? Yeah. So I think a lot of you on the call already know how BCRT started and who we are, but just in case, I thought I would give a little summary of how the charity came to be. So in 2004, a group of parents who'd lost children and young people to primary bone cancer came together. They were brought together by an oncologist, Professor Ian Lewis, who had recognised that the families had all been fundraising independently and felt that they could make a bigger impact by joining. They'd all been fundraising because they'd recognised that there was a lack of research going on in primary bone cancer. There wasn't any information for patients, and there was a real lack of support for families and patients that were going through a primary bone cancer journey. So some of the families did indeed join together, and in 2006 the Bone Cancer Research Trust was formed and registered. So today we are the leading charity dedicated to primary bone cancer, and we offer hope to all those affected by the disease. Our vision is a world where primary bone cancer is cured for all our patients. And our mission is to save lives and improve outcomes for patients through our 4 pillars of work, which we do through research, information, awareness and support. We are a small team, and there's 16 of us at the moment. And unlike many charities, we're not based in London. We are based in Leeds in the north of England. So tonight we're here to talk about awareness. Awareness is one of our 4 pillars. And in 2017, we launched a new 5-year strategy called the Biggest Commitment to Primary Bone Cancer Ever. And as part of this strategy, we set out some key objectives and aims across our 4 pillars, and awareness being one of them. And we said that we would save more lives and increase survival rates through raising awareness of primary bone cancer amongst the public, healthcare professionals, researchers and policymakers. And we have made a start in our awareness work. We have funded a GPE module for a number of years. This module is actually archived at the minute, and we are reaching out to GPs and trying to review the way we educate GPs and work with them. We have an ongoing e-module for medical students. So we run this in collaboration with an oncologist in Liverpool called Mr. Chandrasekhar. So it's a voluntary module because undergraduate medical students have very, very little time dedicated to sarcoma as a whole, and then bone sarcoma, probably not very much at all. So he runs this, and we fund the best students to go on and do a sarcoma fellowship at one of the sarcoma centres. With the help of our GP ambassador, Dr. Phil Green, we made a new symptoms video, which was done at one of our patient conferences. It goes through the key signs and symptoms, and it also has some real life examples of the symptoms patients experienced, and they give their accounts on the video. And last year, through Bone Cancer Awareness Week, which is this week now, we managed to reach over 4 million people with our awareness messaging, and we're really hoping with all your help that we can reach more this year and get over the 4 million. So we are a charity that represents patients. We were formed by parents who had lost children and young people, and patients are still at the heart of everything we do. And a number of patients that we speak with have experienced issues with delayed diagnosis. And I'm just going to show you some of these patients now. So the top little girl is Harmony. So Harmony's dad has provided us a lovely quote. Had this lump been given an x-ray sooner, she would have been in the early stages and also further into treatment. I would love and hope for sarcoma to be considered at every triage a patient has that comes in with an unexplained lump or mass in any bony area. The little girl below is Alice, and again, Alice's dad has provided us with why he feels raising awareness amongst healthcare professionals is so important. Early diagnosis is of paramount importance. The 23 appointments Alice had before diagnosis were with GPs, physios, A&E doctors, and even a consultant orthopedic surgeon who specialises in hip and knee surgery. All of them missed where the 7 centimetre to 9 centimetre tumour was, and none of the medical staff along our pre-diagnosis journey suspected Alice's symptoms could be cancer. And I think this quote really kind of encapsulates the problem. We need to make sure that all of these professionals are aware of the symptoms. It's not just GPs. So here we have Abigail, and Abigail's mum, Ellie, provided this quote for us. Awareness is so important. If caught earlier, it may not have spread to her neck, and she may not have lost as much of her pelvis. As it stands, she could also still end up with secondary cancer from treatment she has received, with it being so aggressive. And at the bottom we have Sophie, and Sophie's provided this quote herself. I think the more awareness we can raise about early diagnosis, the better the treatment outcomes will be. Just one mention of this at a GP visit could make such a difference. So this is something that's really, really important to our patients, and it's important to us. We've got a number of patient stories on our website. So if you haven't had a chance to read these before, please do head over to our website and have a look at them. They're all amazing stories, all worth a read. So why is it important to us that we work with healthcare professionals? In 2015, we carried out an important piece of stakeholder research. And on the back of this, our Living With and Beyond Primary Bone Cancer report was finalised. This document and this report looked at a patient's journey right from diagnosis through treatment and then life after treatment. And it actually gave us our first piece of concrete evidence that delayed diagnosis was a huge problem for our patients. And it's this quote that was taken as part of the patient survey that I found really haunting to this day. When I was finally diagnosed, I didn't know if I could go through the treatment. We had fought so long, I didn't know if I had any fight left in me. And that's come from a 14-year-old with osteosarcoma. And at the charity, we believe that no patient, especially not a child, should be left so exhausted trying to get a diagnosis that they can't face the treatments ahead of them. We know that treatment for primary bone cancer is really, really grueling. So we have to do something about this. In 2019, we hosted 5 medical students from the University of Sheffield as part of their social accountability module. We asked them to look at our education materials and review these, and they actually chose to do a project looking at educating medical students. As part of this placement, they made these flashcards to act as revision tools for medical students. So they're the size of a postcard, they're matte, so the students can write on them and make their notes, they can highlight sections, and it gives details right from risk factors to how the cases present, what investigations you need to do for diagnosis, their treatments, and then some epidemiology on the reverse. And actually we felt that these were brilliant aids for medical students, but they've been taken up by GP practices as part of reflective learning, and they've been used by physiotherapists as well, which is absolutely incredible. And it was really those flashcards that started this current awareness project. alongside of that, we've been working with Children with Cancer UK for a number of years, since the back end of 2018, when we started planning our first osteosarcoma symposium together. And actually, both charities have got a priority around early diagnosis. And so we decided to do something together, and we launched the Bone Cancer Awareness Initiative, which is a 100-day long project. And it started in July, and it's actually culminating this week in Bone Cancer Awareness Week. And the project is called Bone Cancer Awareness Initiative, Saving Lives Through Earlier Diagnosis. And so to start the collaborative project, the Bone Cancer Research Trust launched a new patient survey in July. So if we're going to aim to make a difference in early diagnosis, we really need to know how bad the situation is. So we launched our survey through SurveyMonkey, and it really did have two main areas of focus. So we wanted to know the time and the route to diagnosis for patients, but also the breadth of symptoms that they experienced. So irrespective of an anatomical location of the tumour. So we received 739 responses to our survey. We actually got responses from patients inside the UK and then from some outside of the UK. So we had 426 outside and 312 inside the UK. We're not entirely sure where the patients live that are outside the UK, and they come from a number of different countries. We had one respondent that didn't give their location. So we analysed the results, and we're going to share some of those with you. So I'm going to hand over to my colleague now, Vicky, who's going to talk you through the results.
Hi, good night. So as Zoe said, the survey was really, was surprising how many people responded, and we were extremely glad that it was the case. I'm going to tell you a little bit, but it's obviously just a snap, a very little view of what we discovered. I start from the very beginning, so the demographics. So people responded to the survey that were current patients, former patients, parent of a patient, or friend, or family members of the patient, but all the answers were given as from the point of view of the patient. As Zoe mentioned, we had responses from the UK, 42%, and people who were living outside the UK when they were diagnosed. Although we don't know the location of the people outside the UK, we have made some comparisons. However, we need to take into account that because it's a collection of countries, they will have different healthcare systems, so we need to be aware of that. In terms of female over male responses, overall we received more female responses than male. However, depending on the time of primary bone cancer, that ratio varies. So for example, for Ewing sarcoma, we had a ratio of 1.5 of male over female. So it depended on the type. So could you move to the next slide, please? So this is about the demographics in terms of the age of the patients when they were diagnosed. And we had quite a wide range, so from 1 to 81. The mean age of diagnosis varied depending on the type of primary bone cancer. So for example, for osteosarcoma was 19, for Ewing 16, for chondrosarcoma 42, and for chordoma 47. And that's actually really in sync with the sort of normal incidence of those types of primary bone cancer. In terms of the year when they were diagnosed, again, we had quite a range. We have responses of people who were diagnosed in 1968 all the way to 2020. However, the majority, over 75%, were diagnosed both in the UK and outside within the last 5 years. And that's important to us because for the symptoms, it doesn't matter. The symptoms are the symptoms. But when we try to analyze the route to diagnosis and the time it took to be diagnosed, it's important that we're looking at current answers. So can you go to the next slide, please? So we received responses from all types of primary bone cancers and some non-malignant tumors as well, for example, amyloblastoma here. And in this graph, you can see the distributions of the different types according to the age here at the bottom. And you can see, for example, the orange shape is for osteosarcoma, and it's obviously more predominant for younger patients. The same for Ewing sarcoma in blue. And you can see here chondrosarcoma in yellow, which is for older patients, and also chordoma in green, also older patients. Can you go to the next slide, please? So we asked people to tell us to who did they go first in the first place to report the symptoms, and also how long it took them to get a diagnosis. And from this graph, you can see that in the UK, the majority of people first went to the GP, 76%. Some people went straight to E&E, 11%. Some people, for example, you can see here dentists, that must be people who, or at least indeed people who had tumors in the jaw, for example. And a few went to the physiotherapist. Can we go to the next slide, please? It was clear from the responses that many people made multiple visits to different healthcare professionals, sometimes many of them or one of them many times. And we've tried to quantify that. The average number of visits to any healthcare professional, whichever, for all primary bone cancer together was 8.2 visits, compared to 6.5 visits outside the UK. Now, the average number of visits to a GP, in particular, in the UK was 4 times, and outside the UK, that was 2.4 times. 49% of patients in the UK visited a GP between 1 to 3 times. 29% went to E&E between 1 to 3 times, and 12% visited a physiotherapy between 1 to 3 times. Actually, 19 people visited their GP between 4 to 6 times. 19% people visited the GP between 4 to 6 times, and 5% went between 7 to 12 times. Could you go to the next slide, please? So when they did report the symptoms, what were the outcomes of those initial visits? 21% of patients in the UK were asked to return. You can see here this blue quarter here with the pink outline. They were asked to return if symptoms persisted, and that's okay. You know, it's normal for a GP to say, well, if it gets worse, come back to see us. However, we need to make sure the monitoring and safety netting is put in place, because what if the patient doesn't return or returns too late, and then the disease will be advanced. 28% in orange were referred for X-ray or other healthcare professionals. 38%, which is this area here highlighted with the dark dotted line, felt that their symptoms were ignored or were given incorrect advice. So, for example, prescribed painkillers, which we know and we promote this as part of our red flag symptoms and our symptoms of primary bone cancer, that is not respond. The pain in bone cancer doesn't really respond to painkillers. And only this little wedge here in pink, 2%, were directly referred to a specialist bone cancer center. Can we go to the next slide, please, Zoe? Now we come into time. So we asked people to tell us, after first experiencing symptoms, how long did it take them to seek medical advice? This is what is called the patient interval. And then from that point, after seeking medical advice, how long did it take to get a diagnosis, the diagnostic interval? So we've been able to combine these two together and calculate the total interval of diagnosis for every patient that responded. So let's look at the patient interval. So patients actually did report the symptoms very diligently, particularly in the UK. So 60% of people in the UK, they sought medical advice within 1 or less than 1 month after experiencing symptoms. Less so outside the UK, that was 48%. We tried to actually calculate the percentage, the length of time, and that was 2.8 months in the UK and 3.5 months outside the UK. Can we go to the next slide, please? So now we move on to diagnostic interval. Patients reported delayed in diagnosis in the UK, and this is particularly clear in the UK compared to outside. So 27% of people in the UK, they received a diagnosis within 1 or less month after seeking medical advice. Not very many. Outside the UK, 49% received this diagnosis at the same time. When we calculate that diagnostic interval, it was 6 months for UK patients compared to 4.27 outside the UK. Now you saw there is a little bit of inversion. So although people in the UK went sooner to see the doctor compared to outside, they received the diagnosis later. So when we thought, well, if we add everything together, they would be similar in the end. They are similar, but there is still slightly longer for the UK. So you can see that when we put both together, you get close to 8 months for the UK to overall get a diagnosis, and over 7, or close to 7. 6.6 outside the UK. Can we go to the next slide, please? It was very clear also that from the responses that we received, many patients reported receiving non-diagnosis, misinformation, alternative explanation, and clearly misdiagnosis. And that was the case for, and sometimes many of them, the same many times. 76% of UK patients and 69% of the outside the UK patients received at least one of those alternative explanations. And when you look at that percentage, within those 79 were children, 78 teenagers and young adults, and 73% were adults. So this is quite a sad percentage. Can you go to the next slide, please? So we thought if people are getting all these alternative explanations, they must be going to the doctor several times. So we thought, could we see a correlation between the effect of this having misdiagnosis and the length of diagnosis? So I'm going to go through this graph now here. So in this box here, which is in lighter orange, you have patients that did not experience any of those alternative or repeat explanations that were going anywhere. And here, the ones that did have at least 1 to 6 of those. So the lighter shade blue bar represent those patients that received the diagnosis, the diagnostic interval, in less than a month or 1 month, compared to those that took a bit longer. So when people didn't receive any of those alternative explanations, there wasn't that much of a difference. However, when you look at those patients that did receive those, here outlined with the orange, darker orange square, you see a huge difference. The very few patients were diagnosed soon, in less than a month or 1 month. So clearly this is having an effect. We go to the next slide, sorry. So why were those common explanations, misdiagnosis, non-diagnosis? Growing pain clearly for children was very prevalent. Sporting injuries, pulled muscles were also very common, and that was across all ages. Arthritis, sciatica, for example, tumors that were in the jaw or the skull, they had migraines, tooth abscesses, ear, sinus infections, all those were very commonly reported. So what you see here is the pattern, that age, you see here for growing pains, and the location of the tumor had quite an impact in the type of explanations people are getting. Can we go to the next slide? Oh, and also I wanted to highlight this, sorry. I forgot to say, so the percentage, I should calculate the percentage. So the percentage of children diagnosed with growing pains in the UK was 43%, which is very high. And compared to others outside the UK, which only 23%, very high still, but lower. Sorry, can we go to the next slide now? So after they went through the doctor several times or eventually were referred to a primary bone cancer, especially bone cancer center, who made that referral. This graph shows you the results in the UK. So 17% of people were referred by the GP, but the GP was NHS or private. We put them together for this analysis. 12% of them were referred by E&E. Some of them were referred through X-ray imaging, for example, 11%, or through fracture clinics, 16%. 28% were referred by other hospital consultants, which is giving an indication that people are going to the doctor, they're being referred to a different specialism, which then refers them to the bone cancer center. So there is the sort of like a path that is not in a straight line. So we wanted to explore this a bit further, and we analyzed the results of people who were diagnosed, referred by the GP or by E&E by age. And this becomes quite interesting. When you look at the people that were referred to a bone cancer center by a GP, the age difference is quite interesting. So 11% of children only were referred by their GP, compared to 18% of teenagers and young adults, here in pink, and 21% of adults. If you look at the E&E, it's actually reversed. 21% of children were referred by E&E, 9% of teenagers and young adults, and 8% of adults. So it's quite an interesting difference. Can we go to the next slide, please? So Zoe indicated earlier that there were two objectives from the survey, one to look at time and routes to diagnosis, and the other ones to recognize the symptoms, to report them in detail, and make sure that healthcare professionals know about them. So so we have done that. We have reported the symptoms. So we have collected the symptoms and we analyzed them, and we have grouped them by age, by type of primary bone cancer, and by anatomical location. So I'll give you here an example of what we've done with the lower extremities. So we looked at symptoms of pain, and we have actually quantified. We know the symptoms of red flag, but we have actually quantified them. So you can see how many people reported constant, intermittent, worsening, resistant to painkillers, etc. We've also quantified how many people experience referred pain. And this is important because this referred pain is the pain that's felt not in the area where the tumor is. And if this could be really important in misdirecting healthcare professionals, because you say to somebody, I have a pain in the leg, but the tumor is actually in the pelvis, they might x-ray the leg, not the pelvis, and therefore that would add time. We've also looked at symptoms for, lumps, having lumps or problems with mobility, and general symptoms as well. And out of those general symptoms, fatigue here, you can see with the red arrow, has always jumped out of the page for pretty much all of them. Can we go to the next page, Zoe? So we said that we've analyzed them by age, and I know this is a very busy slide. I just wanted to show you that. So we looked at every single symptom and looked at how many children, how many teenagers and young adults, and how many adults had them, and then mapped them accordingly, whether they're specific or the general symptoms. And so we have tried to record them and produce information materials that are highlighting all these things. At this point, I think I'm going to pass them back to Zoe, so she's going to tell you about what we've done about it.
Thanks, Vicky. So that's a snapshot of the type of thing that we found from our survey. So I'm now just going to tell you about what we're going to do to try and address some of this. So we are working with a special task force that we've assembled to get the right expertise to help us develop things further. So we are working with Krista Bose, who is a medical student. Krista has also had a diagnosis of osteosarcoma. We are working with our GP ambassador, Dr. Phil Green. Again, he's an ex-osteosarcoma patient. Dr. Sandra Strauss, who is a consultant medical oncologist down at UCLH. Sandra's also specialises in bone sarcomas and is the chair of the bone subgroup as part of the NCRI sarcoma research group. Has a lot of expertise in this area. We have Garen Davis, who is a specialist physiotherapist at Oswestry at the Robert Jones Agnes Hunt Hospital, which is one of the specialist bone cancer centres. We have Mr. Jonathan Stevenson, who is a consultant orthopaedic oncology surgeon at the Royal Orthopaedic Hospital in Birmingham, and his colleague, Dr. Rajesh Botchu, who is a consultant specialist musculoskeletal radiologist. So we brought this task force together, and they have helped us to deliver a series of webinars aimed at their peers. So we've done a webinar on Monday for physiotherapists, on Tuesday for medical students. We had 2 on Wednesday, one for GPs and one for radiologists and radiographers. And these have been really, really popular. So they were attended by over 2,000 healthcare professionals, and they have been recorded and are being made available for future learning. So I just want to give you some feedback of the webinars. So we've been doing a survey to get feedback, And before the webinars, attendees, so 43% said they were not so aware or not aware at all of primary bone cancer symptoms and referral pathways. And after attending our webinar, 94% now say they are very or extremely aware, which is an incredible shift. In terms of our webinar, are they going to recommend it and use it further with their colleagues? 95% said that they would share our webinar contents, which is just really incredible. So we've also made some resources on the back of our survey. So we have taken the flashcard that the students developed and we've tweaked it for each healthcare professional. So we have kept in the key clinical content, but added a very important box here, which is what a healthcare professional needs to do if they see a patient that they suspect has a primary bone cancer. And this box here is different for the different healthcare professionals to reflect the different referral pathways that they need to go through. And we have developed a number of posters. So Vicky showed you the data on our symptoms. So we have this skeleton poster here, which lists all the key symptoms per anatomical site and all the common misdiagnoses that patients experience. We have a poster for radiologists and radiographers, just to highlight how difficult it is to image primary bone cancers and pick these out in the images. And we also have a poster for GPs and healthcare professionals, really trying to emphasize it's important to take all of their symptoms in combination and not in isolation to identify a case of primary bone cancer. And actually, the people that attended the webinars said that 97% said they were likely to share these resources with their colleagues and use them further. If you want to, you can download these materials. They're free to download on our website. So if you haven't got a copy, please do download them or email us and we can send copies out to you. So we have sent these out to quite a few people throughout Bone Cancer Awareness Week and the week before. We have sent packs out to all GP practices in the UK, so that's 10,771 practices, all musculoskeletal physiotherapists, so that's 586 practices, medical schools throughout the UK, all pharmacists, so that's 12,811 pharmacists, and all hospitals with radiology departments in them, so 1,542. We know that they're getting there. We've had some feedback that they are starting to receive them and are using them. So we're going to monitor that carefully, make sure that they've all got them. So we've managed to do a lot in this project up to now, but we know it's just a baby step and we know that there's a lot to do moving forwards. So we are still finalising all of our survey results into a complete report, which will look something like this and will be published very soon. We understand that this is a patient survey and we understand the limitations to it, but it has provided us a line in the sand and it's provided the evidence that we can take to clinicians and say this warrants further investigation. So we plan to try and do a clinical study to look at this further. And obviously we need to measure the impact of these awareness things. So this is something that we'll do now and we'll repeat the audit in several years' time to measure any impact that we see on diagnosis. So our primary objective is to reduce the time it's taking for patients to be diagnosed. So we are going to continue these webinars. They've been such a hit, and this is one of the quotes that we received as part of our feedback. This person came to the physiotherapy webinar, thought it was excellent. I have never received training in the area in 20 years of practice. Thought your resources are very helpful and will be sharing with management. And that's something that we absolutely need to change. We need to make sure everyone has access to this training. So we aim to continue offering them at least once a year for GPs and all healthcare professionals, and continue promoting all of these wonderful information materials. So over to you, how you can get involved and engage with this project. If you are a professional, please use our resources. Please contact us. If you haven't got them, we can send them out. If you are a supporter of BCRT, please be an ambassador and spread the word. Ask your GPs if they've received a pack, or any healthcare professionals. Come to our bone cancer conference, and please provide feedback. We are here to support you and try to make things better, and we need your feedback in order to do that. Thank you very much. So I just want to end again looking at our patients. Our patients are our daily inspiration, and it's why we do what we do. Thank you for your attention. I'm going to stop sharing my screen and pass back to Matt.
Thank you, Zoe. Thank you, everyone. I just wanted to add just at one point, if I may. We've kept having a few bits of feedback coming in on social media through Bone Cancer Awareness Week, particularly around pharmacists. So there are some pharmacists on this call tonight, and some of you may be thinking, well, why does it apply to us? In the full report that we're developing, that we'll be launching soon, I would encourage you all to read it. There is information in there that specifically relates to pharmacists and how pharmacists do have, they do have a room where they see patients, and patients report symptoms to pharmacists. So, that from one step, you need to be aware of these potential symptoms to refer back to the GP, but also a lot of our patients are prescribed analgesia and potentially can come back for painkillers repeatedly. So, these are the kind of things that we want you to be aware of. And lots of pharmacists are connected to GP surgeries. So we're wanting everybody to be joined up and have the same information and be, starting from the same point of information when it comes to symptoms awareness. We have sent, literally, as Zoe's just said, over 25,000 packs out in the last week and a half to GP practices, to pharmacists. In the case of pharmacists, it's been addressed to the pharmacy manager. In this case of GP practices, it's been addressed to the practice manager as well. So if you haven't seen the packs, please ask the manager or whoever deals with your post, because you will have them, put them to please good use and make sure that they are given out. Sorry, just thought I'd add that to point. We've got two questions. If anybody else has got any questions, please do pop them into the comments. So Phil K has asked, why is the visits, outside the UK so much lower? I think that's in reference to healthcare professionals from the findings of the actual report. Yeah. So do you have any thoughts, Vicky or Zoe, on why we think that might be?
I can make a start. Yes, they are lower. However, I wanted to emphasize that what we call outside the UK is many countries together. So we are comparing the healthcare system of one country with a multitude of them. So we need to be careful with that comparison. Bearing that in mind, nevertheless, it did seem from the report that what people have told us that it takes longer in the UK compared to other places altogether. Now, it may not be the same if you compare specific countries, so that we need to be careful with the comparisons that we make. Sometimes, almost kind of reading between the lines, I was thinking this person is American, this person, but obviously that's just the way we interpret the data, because I'm looking at every single answer. However, so that's an important thing. So I'm always cautious to think we are making a very straight comparison. Also, you need to remember one thing, and this goes back to the problem of using a survey to produce numerical data. Sometimes there is an element of bias, and in that people who may respond to a survey like this may have a worse experience than somebody else, and therefore that compels them to reply to the survey. So that's another bias element that we need to take into consideration. All that bias together, I still think this is an important point, and that the surveys allowed us to, as Zoe said, make a line in the sand and actually calculate for the first time, really, nobody's reported those sort of numbers before, the length of time that it takes for people here. It doesn't matter how long is outside anyway, it's what is here in a way that's important, that it takes them 8 months to get diagnosed or 6 months to get a diagnosis from the point they got to a doctor. Even if somewhere else is worse, if it was worse, it still would be bad here. And if it's somewhere is better, it's still bad here. So I'm afraid I can't really give you the answer. It could be a combination. We have also interpreted the data by different cancer type. So what I presented, this is a tiny little bit of what we've done, and that it was all as combined. So you have different lengths of times for different types of cancer. And even if we compare, they would be different. So that the biology of the tumor might take place. It might be more difficult to diagnose a particular tumor than other. So that needs to be taken into consideration as well. I don't know if I've answered your question.
Another question from Louise Kirby. Were there any findings from the patient survey which particularly surprised you?
Shall I go? I think
Okay. Yeah.
I think one result that really surprised both Vicky and I was the amount of patients that experienced referred pain. So what I might mean by that is, so their pain was somewhere entirely different to where their tumour was later identified. So patients with pelvic tumours were feeling pain in their legs, and it was 32%. That's an awful lot of patients. And I think that has an important implication when patients are referred for imaging. GPs need to thoroughly make a thorough request for imaging to make sure that x-rays are done in the right anatomical region, because if they were done in the leg, they would miss the tumour. So I think that's been quite shocking, quite surprising.
Yeah, I also thought that although we know about it, that the level of reports of fatigue were really, really high, and they were prevalent in all the different, when we did the analysis by all the different locations and different types. And it's something that really doctors, GPs in particular, when they face a patient, they should really be asking that, because it's not normal for a kid to be fatigued, and many are reporting that. Yeah.
Do you mind if I add to that just something from a lay perspective? Obviously, I've not been involved in the data, but something that I found particularly surprising was the fact that 24% of patients actually reported symptoms to a physiotherapist before they actually ended up getting a diagnosis. So going back to your point, Zoe, about how impactful and good it was that we've done these webinars this week, like the physiotherapy one, you know, in one fell swoop there, if we could reach all physiotherapists, musculoskeletal physiotherapists, that are potentially seeing a quarter of all patients, and they know what to do when a patient is, you know, presenting with these symptoms. To me, that was really quite powerful and something that I never expected to see reading the report first time. Okay, just move on. Another question. So from Ali Garland, do you know, though, if these times to diagnosis are the same for other cancers? I'm assuming for breast cancer, for example, it'd be weeks.
Yeah, it's very true. I think for the more common types of breast cancer, I think even if a patient presents with any type of lump or breast change, a GP knows that it's easy to refer for a mammogram. They do that very quickly without kind of thinking about it. And I think you're right. I think it's within weeks. But there are certain tumor types that are difficult. Brain tumors, for instance. We know of a similar awareness campaign by another charity called Head Smart, and they had the same problem, albeit not quite as bad. I think it was about 12 weeks on average, their time to diagnosis. But through their awareness activities, they've got it down to about 6 weeks. So there are certain tumours that are particularly difficult to diagnose.
I think there's even aside from cancer as well, I think one of the great things that we've now got on the flashcards to all the healthcare professionals is the comparison to bacterial meningitis, because the incidence is around the same, isn't it?
Yeah.
And And, you know, on the GP webinar earlier this week, the GP, our GP ambassador, Phil Green, he was saying to his, his colleagues that they all know about what to look for, whether or not a child presenting could have bacterial meningitis, but actually it is the same incidence as primary bone cancer now. So they know about so much about one, but not about the other. That's particularly interesting.
Yeah.
Okay. So there are no other questions that have come in this evening.
We do have some news. Shall I?
Oh yeah, over to you, Zoe. Share the news with everyone.
Yeah, so today's been quite a busy end to our working week of Bone Cancer Awareness Week. So we have been undertaking a research symposium, an international one, focused on Ewing sarcoma. So this was supposed to be a face-to-face meeting joined onto our patient conference. Obviously, in the current situation, that couldn't happen, but we were lucky enough to be joined by over 100 Ewing sarcoma researchers and clinicians during a virtual meeting, a lot like this, and it was just incredible. It's been an incredible day. We've heard updates of ongoing research projects, some new things that are coming forward, some real hope and promise for the future. And it's just so nice to see. It was a very supportive atmosphere and collaborative atmosphere, and the researchers were sharing ideas and hints and tips. And yeah, there's lots of exciting things on the horizon, we think. And to close the meeting, the Bone Cancer Research Trust were delighted to announce a new funding call restricted to Ewing sarcoma. So we are opening a call for projects up to £150,000 for research in this area, which is a great way to finish the week.
Indeed, and actually that was announced publicly 21 minutes ago whilst we've been on this webinar. It will go out on our social media channels. So anybody on here that knows researchers, please do share it with them. But yeah.
And it's open international as well. So we've just awarded our first ever international grant to a researcher in the States who is incredible. He was at the symposium today. And so this funding call is again open to our international colleagues as well.
Yeah, it's fantastic. So, okay, everyone, we I think bring it to an end there. Got a few thank yous coming in. So no, thank you very much to all of you for attending, giving up some of your time this evening. We know it's quite a late one, but we hope you've found the session interesting and you're taking away something from it. I think the main message is, for those of you that have been affected by primary bone cancer and the effects of potential late diagnosis, we are doing something about it. We have a solid evidence base now, and we are taking proactive action, and we're making sure that we're not just reporting on a continuing problem. We are trying to solve that problem. So if you can take anything away from this week, it is that we are solving the problem, and with your help we will get there. So thank you all for joining us tonight, and we will share a link to the webinar video after tonight, and that will include a link in that email to our downloadable information materials that Zoe mentioned earlier. So by all means, please do share them, download them, print them, spread the word as much as you can. But thank you all for joining us. Good night.
Thanks very much. Bye.
Bye-bye.